Thanks, John. Hopefully I can convince you we can do something. Look, it's 51 years ago since ARDS was published in the journal, and it really took a long time before any real therapy could actually reduce mortality. And you will remember this paper that came out in 2000, the ARDSNet paper, multi-centre study, US 6 mils versus 12, limited peak airway pressure, and it reduced mortality from 40 down to roughly 30%, a big effect. And then a few years ago, Dale Needham's group came out and said, well, you can actually see the benefit of this even further out. And they had 13 intensive care units, and they found that adherence to low tidal volume ventilation occurred in 41% of settings. But if you were 100% adherent to that setting, then you could reduce 2-year mortality by a further 7.8%. And in a subsequent paper, they also showed that settings on admission were also important to settings that occurred later on during the patient's stay. The only problem was that people didn't take this up. No one set the ventilator to low tidal volumes. Maybe it was because clinicians didn't want it. They felt more comfortable having higher volumes. They thought people were more comfortable on it. They weren't aware of the literature in some studies, and for many of them they said this only applies to ARDS, and we know that ARDS is underdiagnosed. And furthermore, some units said, well, I'm waiting for the doctor to write an order for low tidal volume ventilation, so it didn't actually occur. But overall there was poor take-up of it. And then this was, to me, an important study. This was the IMPROVE study that came out, which looked at patients undergoing elective abdominal surgery, randomised to lower versus higher tidal volumes, and they had about 400 patients. And basically those who were in the lower tidal volume, these are normalish patients, had less complications, less need for mechanical ventilation following surgery, and were in hospital for almost 2.5 days. So to me this said was, yes, it's good for ARDS, but it's also good for normal patients as well. So we thought, well, why don't we take out and have a look at our data? And we've got a clinical information system which makes it easy, but now there are lots of clinical information systems throughout Australia, so everybody should be doing this. We queried our database from 2000 to 2013, and we brought out every ventilator setting for those patients in whom we had height recorded, and I'll mention why in a minute, and those who had either volume control or pressure control. And we did find an adherent tidal volume to one that was less than or equal to 6.5 mils per kilo predicted body weight. Not actual body weight, not ideal body weight, but that one that was calculated by the ARDSNet group. And it's quite a low weight. You know, a 170 centimetre man has a predicted weight of around 65 to 66 kilos, pretty light. And what we found, we had nearly 5,000 patients, 250,000 measurements, and we found we were only adherent to low tidal volume ventilation in 13% of those settings. We found that we were more likely to if you were a man, if you had later duration of your ICU stay, or if you were sicker in that you had higher PIPs or higher PEEP levels. We were a little better in doing it, but nowhere good. And then I thought, well, maybe things have moved on, but for those of you who read Critical Care and Resuscitation, just the last edition, you'll see this is an audit taken in 7 ICUs in Victoria, 123 patients. The most typical ventilated mode of tidal volume is 500 mils. Still, 38% of those patients were exposed to tidal volumes in excess of 8, and it was more so in women than in men. So we, back in 2013, said we've got to do something about this, it's not right. So we all as a group said we're going to make it mandatory that every patient coming through ICU is going to be ventilated with 6 mils per kilo predicted body weight, which meant that we had to measure the height of patients, and that usually meant their demispan, because you don't have tape measures to measure whole patients in ICU. We undertook education sessions for nursing, medical and other people. We had literature to show them why we were doing this. And I think one of the most important things was that every intensivist on the ward round had to check the ventilator and say, are you doing 6 mils per kilo tidal volume? It became just part of that. Well, we were lucky that we had a medical student, Celeste, who worked with us, and she took out another data set. This now was between really 2012 and up to about 2016. Again, lots of patients, and found that our adherence had gone from an abysmal 13% up to 26%. So we could actually see it rise. But it was only for a short time after that was implemented. And as you know, people get tired. They get sick of you saying, are you at 6 mils per kilo? Or the consultants might forget to do it because, you know, they're busy. So in this most recent one, I took out the data from January 2012 to the 31st of December last year. Again, all people with height recorded had to have volume control. I did do the spontaneous ones as well, and I won't present that today. We took out all their ventilator settings that they had recorded. Again, the same definition of an adherent tidal volume, and again, we looked at some of the factors. Again, 4,000 patients, median age 65 years, 70% men. They were all a little bit overweight. The median body mass index was 28. A lot of these people had cardiac surgery because they were the ones who came with height recorded when they hit the unit. Our mortality for the patient cohort was about 11%. We had 100,000 separate measurements, and again the factors we found associated with adherence were being a man, being younger, being later in your ICU stay, having a lower BMI. If you have a high BMI, people sort of tend to underestimate they tend to think you should have a higher tidal volume. And if you had worse function. And now, you know, we've gone up to about 38% over those years. But have a look at the impact of years. In 2012, before the intervention, we're at 13%. Immediately after, 30, 40, 46, 47, and we're up to 57% of ventilator settings last year were now compliant. I then put in the ICU consultant roster and said, how good were each individual doctor? And this is what it looks like. Each line, and I'm not going to tell you who it is, but I think the take-home message is that we all weren't very good, but we've all sort of moved up in the same direction, and we are all getting there. So it's just not restricted to one or two individuals. And I quite like these interrupted time series analysis because it's a good picture and it has statistics beside it. So basically, this is our trend before the intervention. We're bad, 12, 13% and heading down. We put in the intervention, and within a couple of months we had this kick up that Celeste was able to show in her paper. But look at what's happening. We are still on a steady, steady rise. And this is years after it has happened. So my summary from this study is I think there's good evidence a low tidal volume ventilation is good. When measured, the adherence of people in intensive care units is poor. I think a targeted intervention can make a difference, but you've got to do it, you've got to say for all patients. If you say just ARDS, you're going to miss people with lung injury because no one makes a diagnosis of ARDS. And because it is good for people with normal lungs as well. I think you've got to make it as unit policy for everybody. You've got to say this is how we do it in our unit. And I think the intensivist taking the ward round has to take responsibility for the ventilator setting, just as they should for the hemofiltration sort of setting. These are all things that we have to do. And the last point I make is that while you'll get a kick up, you'll see improvement early, it takes time to change culture within units. And we saw this with medical emergency teams. You won't get an impact after 2 months of training like happened in the MERIT study. You've got to be prepared to wait for many months and for many years. Thank you very much.